So I just wanted to ground a little bit of our presentation today also in some ongoing work that our organization has done around articulating our research principles. CBRC was founded in 1999, during well over 2 decades ago, and the work that this organization has done has often been quite unique and different. I came into it in 2017 in terms of my own leadership within the organization, and one of the things that I think we've realized over time is that how we work is what makes our work unique and special. And sharing how we work is an important part of being able to disseminate our practices to others, but also to hold accountability for the ways in which we want to work and be in the sector. And so our research principles are publicly available. They're on the website. The URL is here on the slide. And there's a number of different research principles that we share for all of our work, but then also 3 specific principles related to partnerships. And so I would encourage people to think about when you want to work in partnership with the community, what are some of the principles or values that guide that? And as someone who comes from a university institution who often has memorandums of understanding or letters of agreement or subcontract agreements, which have a lot of legal text that cover a wide range of things, including intellectual property, dispute resolution, driven management of finances, liability, etc. I think really thinking about how can we bring in a different or supplemental set of values to that work is important. So I encourage you to check those out and see. We've also included here on the slide 3 of the values that come or principles that come from the larger list for all of our work. And so for us, really thinking about access. So how do we do research and who gets to participate in it? That's been especially important for us because we go out and collect primary data, meaning that we create relationships with research participants who then choose to participate in our studies. And so that's one piece, but also thinking about access in the sense of what do we do with our information? And I think we've gotten very good as a health research sector of collecting data. When we think about administrative health data, there are oodles. We've got lots of information about people. And so how to create access either to that data or to the outputs that come from it, and really making sure that we're thinking about how do the findings that we produce get shared and who gets to participate in assessing those in terms of them being valid or them being reflective of their experiences, and how do we make ourselves accessible as researchers to the community, that we have a direct relationship or visibility for the work that we do. Community empowerment is obviously a big part for us as well. This is really thinking about who has systemically been ignored, erased, not mentioned, not included in a lot of the work that happens. And so for us, we're really thinking about how do we create opportunities for Two-Spirit and LGBTQ people to participate, to lead, to make decisions and research. And I think we're in an era where we've had lots of conversation, especially over the past decade or so, in terms of CIHR's strategy for patient-oriented research. And we really want to try and push those boundaries in terms of what are the roles of patient partners. And of course, we really believe in broad definitions of quote patients in this regard as well. And so for us, it's really thinking about how do we arm community with new skills and new knowledge. And for many years, CBRC has been involved in a lot of capacity building and bridging programs to try and directly increase capacity within the community to participate in research, to critique research, and to lead it. And then lastly, really thinking about impact oriented. What gets me up out of bed during every day is this concept of what is the change that we're trying to seek in the world and how are we going to make the world a better place to be? And so when we think about doing our research, this is not just about trying to understand something and leave it to someone else to be the responsible party, but really understanding that even if we don't carry the agency ourselves to make the direct change we want to see in a system, in a practice, in a policy, that it is our role to try and build relationships with those stakeholders, to try and help them to get access to and understand the work that we've done, and to try and provide them with all that we can to make those changes. And so again, I think really thinking about during the work that we do can have an impact, and how do we maximize the potential impact of that? I'll just invite Anu if you've got thoughts or other things you want to add around the principles. I know you've obviously been a key part of building and articulating these.
Yeah, thanks, Nate. I think the only thing I want to say is to just bring us into this moment. I'm thinking a lot about this piece around action oriented. Like we have to bring into the room the really kind of scary context that we're in right now, right? Rising and legislated transphobia. We see, yeah, I think lots of people in our community and communities beyond it are reeling from what's happening. Just sort of reading today about the fact that so many refugees who are in process to arrive in the US, their travel plans have been canceled. So just thinking like, what does action really mean? And how can all of us participate in the different ways that we approach that into the action? This is a time for showing up for each other. Yeah, just wanted to name that. And I think a little bit about, there's the how we do the work. And I feel like this question, this slide is asking us to think about is why we do the work. So just a quick little note, if you're getting distracted by my looking over here, I have 3 screens in front of me to help me organize information. And so just looking over here at notes, and I come back to look at you and see your names. Um, so here, this is like the briefest way of talking about the complexities and the relationships between our communities and health data collectors. So I just want to name that, like so many other communities that experience systemic oppression and marginalization, systems and structures and policies of health and of research have not always been kind to our communities. And many would argue that they continue to perpetuate that. And what that means is, either researchers or public health practitioners aligning with what might be legislated homophobia, biphobia, transphobia, racism, or a kind of like a value description, right? Is basically saying like we're undervaluing certain communities, so we're going to think about them in particular ways. We're going to count them or we're not going to count them. And so there's a long history of that happening for our communities, in particular when people might have one reference point. So before homosexuality becomes like decriminalized, or before it is removed from mental health tools like the DSM. So that's part of the history, but there's so much more that we can say in terms of intersecting oppressions here. So thinking about the ways in particular that Indigenous folks and Black folks, across Turtle Island have experienced healthcare systems, have contributed to healthcare systems without recognition, and also have been counted or not counted in particular kinds of ways. So I want to name that there's this fraught history. It's not a nice, neat story that we're telling about our communities and the interactions we've had. I feel like we're in a complex present moment. So we have lots more folks from our community who are participating in research processes, whether that be as participants. We definitely have more people who are now leading research projects. There's still some underrepresentation of which identities. I think that's an important conversation for us to have always. And yet we have, like I just mentioned 2 seconds ago, we've got this kind of political social context that we need to grapple with. And there still continue to be many who work in health data and healthcare and research spaces broadly, who do have homophobic, biphobic, transphobic, racist, xenophobic beliefs, whether they are saying them explicitly or not. And that's something we need to contend with in our research environment. And there's a question a little bit about what the future holds in terms of the relationships that we have with these concepts, these practices, but also the institutions that often have a lot of money to make decisions that could impact communities in significant ways. So, there's this growing awareness. I think there's also something to name about organizations like CBRC, and there's many others who are doing community-based research and really trying to disrupt the ways that research has traditionally been thought about or talked about or practiced. And I think we need to continue that conversation. We need to continue to create spaces and opportunities for people to participate in work that is by us and for us. I'll just pause here and see if Nate wants to add some comments here
Yeah,
too.
thanks, Anu. Yeah, I mean, there's so much we could have talked about in terms of this piece. And I guess just to highlight a few other things that come to mind for me, I think the particular histories that our communities have with medicalization and pathologization, is that, I don't even know if that's the right conjugation, but pathologizing our, doing our identities, our experiences, our lived realities is a really important piece of understanding, to the piece that Anna brought up earlier, some of the cross-generational pieces. And so one of the things that I think about of working with people who during our youth, as well as seniors and across that age spectrum, is that people in our communities have lived through very different lives, especially whether they've been here in Canada the whole time, or in other parts of the world. And so understanding the way in which psychology, psychiatry, Jordan has said, do you know what I mean, our existence is during a pathology, it is an issue. Understanding the ways in which some of our communities have access to certain kinds of gender affirming care and how that is shaped, who waits longer for that care than others. These are important parts of what our relationship is to the medical and health system. And that has created obviously lots of distrust, and lots of uncertainty around things. It also, I think, speaks to this question of agency, and who gets to decide who knows what about us. And so when we think about the purge in Canada's history, and the fact that state-sanctioned efforts to remove people from our communities from employment and from during positions of work, that is not so long ago in our history. And I think it's important whenever we're doing any of this work and with any community to understand the history, right? We talked a little bit about that in terms of land acknowledgements and reconciliation. It begins with truth. And being able to understand the truth of the communities you work with is incredibly important for any scholar or analyst that's working on particular issues. And for us, that's why we have these long-standing relationships in terms of our community-based work with these particular communities. And I also just will name during as part of our histories, I mean, CBRC did not work with to us LGBTQQIA plus people from the beginning. This is an evolution of our own organization over time to recognize the needs, the connections, the opportunities, and the possibilities, as well as to respond to questions from community about doing broader work. We started as an organization that was really much more focused on gay men and HIV and the problems and the response that were happening around that. And so as we evolve, we need to learn more, and we need to understand that it's a different history and it's a different piece. So there are a number of things within the Canadian system, despite the fact that we are often carrying many rights protected in different forms of legislation currently in Canada, especially in comparison to other parts of the world, that there are very damaging and harmful histories particular to our communities here as well. And that's important when we're working through these administrative systems. And so just maybe, I think then to transition a bit to the admin health data side of this, we're ecstatic to see, do you know what I mean, well over 100 people here in the room today, and know that there were hundreds of folks who registered, and hopefully will be able to watch this when they're able in the comforts of their own home or office. And there's a lot of interest in administrative health data amongst equity scholars, amongst health researchers, and we're so glad that you folks are here providing this platform to talk about big ideas, because for me, I'm super excited about this kind of intersection of the administrative data work and the equity pieces. And I think there's such rich conversations for us to have. And hopefully you can take something away from today that's useful for yourself and your own understanding of this work. But what I will say is, it's not necessarily a concept that's very well socialized or understood within community. Even though many of us access and interact with healthcare, it doesn't mean that we necessarily understand what administrative health data work data means, what it includes and what it doesn't, and all of the kind of systems that exist around it. And so part of our own getting into this work as a community-based research, I had some questions that were kind of like, well, we're meant to be community grounded and center lived experience and doing all of these principles that we talked about. So how does that intersect with administrative data? Can it be done? What parts of it can be done well and what can't? And I think those are really important questions for us all to grapple with. And so as we've worked and started getting more into our own research within administrative health data, we've been doing a lot of learning and thinking ourselves. And I will say a huge part of that has been thanks to Radha. And so she's going to talk a little bit more about some of the ways we're thinking about that within our studies.
Thanks, Nate. I'm actually just going to show you this slide that has a lot of text on it. I apologize, but we wanted to share verbatim some of the ways that we've been framing this. We've actually got a CRHR funded project related to administrative health data and linkages. And there's one arm that's focused on qualitative data collection, so interviews and focus groups. And so we've been working a lot on trying to think about how to describe admin health data to folks in our community in a way that feels understandable, in a way that feels real, like you can see in your mind, I went there and this thing happened to me, or this thing is what I asked for. So if it's okay, I'm just going to read it verbatim just to give you a sense of how we're framing it. And we just got RV approval for this, so we're excited to be doing that work soon. So administrative health data is information about how you've used public healthcare services, such as when you went to see a nurse or a doctor, participated in cancer screening, or received a vaccine. This data includes tests run, diagnoses, medications provided, and how the nurse, doctor, or other healthcare provider describes you in basic demographics like age, sex, etc., but does not include the detailed notes from your visit. It's collected and stored by your government and used to understand healthcare use and statistics as a way just to say, like, this is a big body of information that is really complex, lives in different ways, is used usually at least a few years after it's collected. And that's very different from what we're asking people to participate in our in terms of our studies at CBRC, which is really like community-based. We're on the ground, we're on the road in front of people, usually at community events like Prides. So I just wanted to offer up that the pre-work of trying to think about how to talk about this huge range of data, it kind of requires getting out of the sort of silos and like jargony approaches. We become so used to technical language, I think, in certain spaces, and that's what we need to kind of flip on its head. And a little bit later, we'll tell you more about this project that we've got, because we're really quite interested in both the linkage and also engaging with community members directly. We've got another reflection prompt for you here. So for those of you who are working in admin health data already, we would be really curious to know. And if you're not, but you kind of have heard about and maybe you've had some conversations, how are you describing it to other non-researchers? We have had lots of conversations with other folks about how they've described it, but we always want to learn more. So I'm trying to keep an eye on the chat a little bit too. So when I'm not talking, I'll look over there, and thanks in advance for sharing any of your reflections. And I'm gonna pop over to Nate again to get us started on this slide.
Yeah, so while folks are thinking a little bit about that reflection prompt and how we talk about administrative data within during the various kind of non-expert groups that you work with, I just wanted to talk a little bit about some of the ways that we see and think about our communities within administrative health data. And so first and foremost, it can be difficult to identify our community within administrative health data, as we're not always readily willing to disclose this information, nor are the systems and programs designed to collect or capture it. And some of that, as we talked about, are because of some of these kind of structural issues within Canada, both in terms of thinking about historic harms and ongoing harms, but also in terms of the ways in which we just don't, as a kind of cis heterosexist world, don't really think about our communities first and foremost. And so this difficulty comes from a different a combination of privacy protocols, a desire for anonymity amongst some of our community members, especially given these histories of pathologization, and also difficulties in defining and including measures that are along the continuum or the realities of diverse sexuality and genders. This is something that we talk a lot about, and I can think about StatCan standards around sexual orientation and the ways in which we collect data, and the desire to have standards often mean that we have some kind of fixed response forms, and that can be quite challenging for people in our community who are actively working to queer and disrupt these kinds of boxes and these more limited ways of understanding humanity. We also, during this aspect of sex and gender, just in and of itself, is a fraught concept. Do you know what I mean? And we have done lots of work within the health system to advance understandings of sex and gender. And I have been I'll just say from my own perspective, quite shocked at how slowly this learning is coming into practice. Even sitting on grant review committees and things like that, there is still resistance to some really basic understanding of the differences between sex and gender. And then when we think about these administrative health data, we can think about assigned sex at birth. We can think about current sex. We can think about current gender identity and administrative gender identity. And we can think about anatomical inventories. We can think about a whole suite of things that really kind of cross this gamut of sex and gender. And realistically, when we think about sex or gender, these are fundamentally proxy measures. right? And even in a gender sense or even in a sex sense, these are often meant to capture and convey information about a much broader array of things. And it assumes often this alignment between what might be going on with someone's hormones and someone's genitals, during their chromosomes, and then similarly on the gender side, thinking about identity, expression, potential roles, etc. So there's a number of reasons that limit the ways in which we can be understood or even identified within administrative health data as a community. And then I think the other part is that there has been some work by some really incredibly smart and brilliant colleagues around trying to think about the use of algorithms in terms of trying to think about what can we use in terms of people's healthcare utilization experience to try and predict who might be more likely to be part of our communities. And we can see that work around trans communities. We can see that work around testing for men who have sex with men. And so these are ways in which people are trying to think innovatively about using methodological advances to identify our community that otherwise there is no single marker within a health admin system to identify us. And those are conversations that we're really interested to have in community as well. Julian, so what is currently being practiced? What are best practices? How do people react and feel about those things? And to know that the ethics of practice are dynamic. They shift as times shift. And they certainly, I think, will shift as socio-political context shift as well. And so I think this is something that we need to realize that even if we get an answer one day of this being okay or this being the right way to do things, that consent is an ongoing process. And when we think about community consent within an ethics framework, it's important that we create space for things to shift and that we are accountable to that as researchers, as analysts. Is there anything you want to add on this, Anu?
Just one quick note that I've been thinking a lot about for a long time when we talk about healthcare system utilization. You know, I'm in Ontario where we've had a whole reorganization of not just primary care, but other parts of the healthcare system too. And I want to name that there's a huge gap in terms of understanding the experiences of people who do not have access to public healthcare. And so there's thousands and thousands of people in Canada who interact with healthcare systems who do not have a personal health number or a health card. And so they don't appear in our administrative health data. And that includes people with precarious immigration status, you know, that includes folks who are coming through as seasonal workers. You know, there's a whole conversation that we need to have about how we can better understand the experiences of folks who are using the systems, interacting with them, but most likely paying out of pocket for it. And we don't yet have a way to talk about that in a Canada-wide structural way, but there's incredible organizing and activism around this. I'm thinking a lot about, you know, OHIP for All in Ontario as a group, or Health for All, bringing folks together to have this conversation specifically. Maybe I'll pass over to the next slide. It's a reflection prompt from Nate.
Yeah, just wanted people to think a little bit about, and I'm sure people do think about this question quite a bit in the work that they do. But I think one of the pieces that we often think about is the disconnect between that direct relationship of a research participant and administrative health data. And so when we're doing interviews or focus groups or even surveys, during the relationship between us and a participant is more direct, and their consent is often more explicit in terms of the use of their data. And so we just wanted people to think a little bit about how would it feel if you read public coverage in the news or in a media release on research that was on your own personal communities? You can think about various ways in which you identify or connecting to the world that use data that you didn't know existed. And I think this is an important place for us to start from, is like, where is the potential to do harm? Where's the potential to do benefit? And how do we think about kind of carrying some of these concerns forward? And I think one of the pieces that I often think about is we do research, and sometimes there's a way of thinking about this that we produce neutral evidence. But we definitely live in a world where our evidence as researchers, as scholars, is taken up in politicized ways. And the same findings and the same work can be used to argue very different perspectives than might have been intended by the people who initiated the work. And so just wanted you to sit a little bit in some of the feelings. I think this is something as an epidemiologist who was trained in a quantitative, heavy and strong program. We didn't spend a lot of time thinking about some of these things in our training. But I think it's a really important piece that connects us to our humanity, that connects us to our experiences that we talked about earlier, that I do think can be a helpful gut check in terms of the ethics of our practice. And so just to think about during the responsibility that we carry as people working with these data, during and talking about these data and what we do. Anything you want to add on this, Anu?
No, I think I'm going to keep this going, but just an acknowledgement that there's like some really brilliant conversations happening in the chat. So head on over there if you're not there already. I want to just quickly talk very briefly. This is like the most high level way to talk about a very large research project at CBRC, but we wanted to kind of introduce this because we're going to be making some references to some data that we collected through our health and also some learnings and plans that we have for that further administrative health data work. So really quickly, CBRC's been doing community-based research in this large scale way for a long time. We celebrated our 25th anniversary last year, but over 2 decades of doing large-scale community research in a way that is appropriate for our communities, that reflects community needs. And we got some funding start of pandemic times from the Public Health Agency of Canada and the COVID-19 Immunity Task Force. And so we're just going to be talking about the 2022 version, which was online, but we launched a new survey, a community health survey that was Canada-wide for all 2S LGBTQIA plus people. It's the first time that CBRC did a survey that was inclusive of the fulsome parts of our community. And this ran basically the end of spring, beginning of summer to just before the fall started in 2022. And we had this focus on chronic health and COVID-19, impacts of COVID, experiences during COVID, vaccination, all kinds of things in there. And then we had a very fulsome module about chronic health, which, is some of the only data that we know that we can rely on. That's like all of community and asks a lot of really important questions. And there was an optional, this is a side note for those of you who like this kind of thing, there was an add-on dry blood spot collection in the survey. So we asked people for a small sample of blood. We screened for HIV, Hep C, and syphilis, and also COVID-19 antibodies. So we could get a sense of both how COVID has impacted our community, but also vaccine-induced immunity. So you'll see a few references from some of the data that we've collected. And if you have questions about our health, Nate and I are always happy to talk about this with you.
And so I think that context is important for me because no two studies are the same. And for us, as we've kind of talked about, we try to take a lot of intention in terms of how we create a study, how we implement a study. And that includes the visuals that are here on the slide. Do you know what I mean? The language that we use, the questions that we ask, the response options that are available to participants, their ability to select more than one response on certain things, where often they're asked to just choose. And so there's a lot of intention in our work. And then obviously we talk about who we are in terms of doing these studies as well. And so we asked questions at the end of the study about people's likelihood to consent to share different information about themselves that would be required or beneficial for administrative health data linkage work in the future. So this is kind of prospectively thinking. And my view around this is that this is the most optimistic response that we can expect, because we've done in many ways all the things that we think we could do. And not that we're perfect, to be very clear, we have lots of things to learn and to improve on. But for me, when I think about this, we're talking about working with 2S LGBTQ people in direct relationship. We're talking about them being in a study context that is by and for 2S LGBTQ people, do you know what I mean? And that where they've seen and experienced a study where hopefully they feel quite validated in their experiences. And so if this is a different study context, during the responses to these questions, even from our own community members, might be different. And so I think the context is important for where these data come from. But in general, I'll also share that Anu and myself, to some extent as well, were quite surprised with the receptivity of this. We really weren't sure how skeptical, how resistant people would be in terms of sharing this kind of information with themselves, because we've often run our surveys in ways that provide the opportunity to be anonymous or non-nominal in their participation. And so that's often been an important piece that we hear from our community, is that we're willing to participate, engage, and share data, but we don't want you to know necessarily who I specifically am. And so 60% of people said they'd share their date of birth, 40% said their full legal name, and you can think about the complexity of naming within our communities, and a third of people said they'd share their personal health number. And so this is amongst the sample of people that were in our Health 2022 online survey. I will say, interestingly, and we're not going to share all of the slides and tables and things related to that, but these numbers did not vary by a lot of sociodemographics. And so we looked at age, sexual orientation, gender identity, trans identity, sex assigned at birth, disability, geography, and education. And I did note, I think Michael has put some beautiful thoughts and reflections in the chat, just thinking about ethno-racial identity. And so we did actually see some variation in that within our study. And I just briefly to mention, the people who were more likely to opt in to sharing this information were Indigenous folks, were Latin folks, and Middle Eastern participants. And again, you can think this is within the context of our 2S LGBTQ study. And there were also people who were less likely to consent to sharing these things prospectively. And those were people from Black communities, from South Asian communities, and South or Southeast Asian participants. I share this briefly because we really just want to say this requires a lot more conversation, a lot more thinking, but it speaks to the importance and the diversity within our community and also within broader society that needs to be attended to in the ways in which we approach things. And so there's a lot more work that we can do. And to Amy's question quickly in the chat, these things didn't vary hugely by province. In some of the provinces and territories, we have very sparse numbers, just to be transparent around that. But I was surprised at how little variation there was, really, except along this line of ethno-racial identity. And I think that speaks to important histories of racism, xenophobia, during cultural bias, et cetera. So that's just a little bit around the consenting to share. And then Anna, if you want to just share the next slide. We also asked a little bit about different potential forms or domains of administrative data that people might be willing. We didn't see a lot of variation in this as well, with it there being a little bit less comfort around reasons for doctor's visits within the community. So this tells us a little bit about how we need to think about our communication plans, how we need to think about our consent processes as we go forward in doing this work. And I think what's important also for us is that these are obviously mediated by different social determinants of health, including racism, socioeconomic and class privilege, et cetera. And so those frameworks that we bring into our analyses as population health scholars and analysts is really important. And so for us, that's one of the things that we want to layer in. Even dependent on whether we have great sources of data to measure that, it's a part of our analytic interpretation is understanding what is probably going on here. And so connecting theory with data, I think, is a really important piece for us to be attentive to in the admin health data space, especially when working with marginalized communities. Anna, as the lead of the study, what else do you want to add?
There's so much that I could say further. There was a question about if we asked a little bit about concerns, and we asked people to share a little bit about why, and we're not sharing that data yet. We need to do some further analysis, but we did have a question about like, why do you want to tell us more? And I think based on my initial skim, there's some really interesting things that people are sharing there that are important for us to consider. I'm going to keep us going because I do want to get to the Q&A because this is a really brilliant group of people here based on the chat. So really quickly, we're thinking a little bit about chronic health. Of course, the survey had a focus on it, but I think for many of you who are thinking about healthcare utilization in general, it's really important for us to talk about the distinct experiences of people living with chronic health conditions. So sometimes we understand what's happening in the system based on healthcare utilization, but for our communities, access to healthcare makes telling the story a little bit more complicated. And this is just a snapshot. It's supposed to be small on purpose, just to give you like a little kind of teaser, but we have a data dashboard just with a few kind of indicators from the Our Health 2022 study. But within that, we did ask some questions about how people manage their chronic health conditions, because we're expecting that there's going to be, maybe like specialists, and there's going to be lots of people within the healthcare system that our community members who are living with chronic health conditions interact with. But a very, very high number of people talked about self-management or management with loved ones. And we know that this connects back to this piece around barriers to accessing healthcare in general, barriers to accessing affirming healthcare. We know that people face barriers in accessing diagnosis. We actually have a question about that in the survey too. And of course, the usual kind of barriers that we might expect people to talk about. we suspect that they're probably exacerbated for certain parts of our community, right? Not just the wait lists or services not being available because, you know, someone is full up or you don't have a family doc, but also if you're located in a smaller community, if you've only got like one doc in town. I don't know if folks saw this news report from small town, I think it's Walkerton, Ontario. 5,000 people waited in line to get on to be a patient of this family practice. Not all of those people made it, of course. So just thinking a little bit about like complicating conversations around healthcare system utilization.